Good morning, everyone, and welcome to today's webinar, Evidence-Based Approach to Unexplained Infertility. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Additionally, we encourage you to submit questions to Dr. Benjamin Lannon using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speaker. Dr. Benjamin Lannon is a reproductive endocrinologist at Boston IVF, practicing in the Portland, Maine, and Portsmouth, New Hampshire locations, as well as virtual appointments. Dr. Lannon grew up in Exeter, New Hampshire, and received his undergraduate degree from Dartmouth College and his medical degree from Brown University. He also obtained a master's degree in evaluative clinical sciences from the Dartmouth Institute for Health Policy and Clinical Practice. He completed his residency in obstetrics and gynecology at Beth Israel Deaconess Medical Center and Harvard Medical School, and his fellowship in reproductive endocrinology and infertility at Beth Israel Deaconess Medical Center, Harvard Medical School, and Boston IVF. Dr. Lannon's clinical interests include LGBTQIA+ family building, patients who have experienced a miscarriage, endocrine disorders affecting reproduction, and surgical treatment to optimize fertility. He has presented and published his research nationally. Okay, we are going to get started. I'm going to pass it over to Dr. Lannon.
Thanks, Alyssa, and thanks everyone for joining us today. I appreciate you taking time on your lunch, which I'm sure you use to do other work to actually learn something. So that's great. And I know we've all gotten very comfortable staring into these blank boxes to do these conferences these days, but it's always a little weird for me when I can't see the audience. So I'm going to just kind of go through my slides, and then we can take questions at the end, and I'll try to keep it fairly light here as a lunchtime topic. I'm going to talk today about unexplained infertility, and this is a topic that I think many people end up seeing, certainly as a reproductive endocrine infertility person. This is one of the more common things I see, but I think it is something that often starts in general gynecology practices and primary care practices, and something you see. And it's I think a tricky topic because it's not a very well-formed medical diagnosis, and I think this confuses the people and patients that we're dealing with, but it also is tricky as a physician to kind of decide, well, when do you decide this is a problem and move it on up the scale into something that people need to see a specialist for. So I'll try to go through this in a slightly different format than just kind of a traditional medical talk. I'm going to just talk about it sort of a little bit from the patient perspective and kind of from an office-based counseling. How do we talk to people? And then I'll go through some of the evidence. And this is one of these topics that doesn't have a great amount of evidence, but there was a recent committee opinion by the ASRM that kind of goes through the best evidence we have, and I think it helps kind of answer some of those questions that we have about, okay, well, should we be doing this or not doing this? And yeah, so we'll go from there. So we'll take it from there. So I have a few general learning objectives. We'll just understand the principles behind this ASRM recommendation on unexplained infertility and guideline. We'll discuss some of the evidence. We'll review the recommendations, and then talk about any kind of questions and future things from there. And I don't have any conflicts in presenting any of this. So, with anything in medicine, you try to start with a definition, and I think this is the hardest part sometimes with this condition, because we're not just saying, okay, well, it's this lab test or this, cluster of symptoms or criteria that you're diagnosing it. So, even just coming up with a definition is tricky. And if you read some of these guidelines or reports, it's not standardized across what people are calling unexplained infertility. So in general, there's some factors that are, age-based. So, a female partner under 40 is kind of considered in the diagnosis. And a lot of times these definitions are made for research protocols so that you can actually, standardize things across. But obviously, a 40-year-old trying to get pregnant for a long period of time and a 26-year-old trying to get period for a long period of time, you're going to have slightly different recommendations, but some assessment of age needs to be taken into account. Some patency of a fallopian tube. So again, if somebody has testing and identifies that they have blocked fallopian tubes, then you have a diagnosis there, or if they've had surgical removal of their tubes. It often comes up, well, what if one tube is blocked? And there are lots of people who have tubes removed for different reasons who still have quite normal fertility, and so having one fallopian tube is considered sufficient to get someone pregnant. And I think another, while we're just talking about this, one of the other questions that comes up is like, does it have to be on the same side as the ovary or the same side as ovulation? And even though in the anatomical drawings of the fallopian tubes, everything is sort of stretched out to the side and the ovaries seem like they're connected to the fallopian tube, in reality, everything's sort of sloshing around behind the uterus. And so, we've all heard of cases of somebody ovulating on their, has one ovary in the opposite tube and they can still get pregnant. So, a lot of times people get hung up on this theory that, if they're ovulating on the left and they don't have a left tube, that there's no way they can get pregnant. And, that's not always true either. Documentation of ovulation of the female partner. Again, many people and patients figure this out on their own before they come to see us, and they say, yeah, I'm ovulating or I'm not ovulating. But taking some moment to kind of establish that definition is obviously important. And there are people who have kind of irregular bleeding that think they're getting periods, and sort of going through your set of questions of, okay, well, are you getting a regular cycle? Is it predictable? Do you have kind of those symptoms, premenstrual symptoms that indicate progesterone? All of that can give some testing, or you can do testing of progesterone levels to document that. And then semen analysis with an adequate number of motile sperm is another component where you say, okay, well, these people have sperm. So I'm not going to go into, each of these sections could be a talk on like age impacts on fertility and, diagnostic imaging for evaluation of fertility, or, ovulation evaluation of sperm. So I'm not going to go into each of those sections, but just more talking about a couple that's kind of come to you and you've done some preliminary testing or some testing has been done, and you're like, okay, well, how do I interpret this when everything comes back kind of quote unquote normal? So we'll start with a case. This is sort of representative couple, but a lot of these parameters could change. But here's a 28-year-old, never been pregnant, and her partner, and they, this is sort of a follow-up. You saw them originally and did, kind of a basic set of testing. So in that basic set of testing, some evaluation of tubal function, some, kind of description of their ovulation cycle, and a semen analysis are kind of the pieces that we need to kind of understand what their fertility is. Testing egg reserve and all of that is kind of stuff that we do when we're helping try to figure out treatment options, but in reality, that's often not necessarily part of like the fertility evaluation where you say, okay, well, do I need to know this person's day 3 FSH to know that they're ovulating or that they're capable of getting pregnant? So, that may be part of your evaluation, but, in general, we want these kind of pieces to understand. We have some history that they've been trying to get pregnant for 14 months without any pregnancy. Maria has been, gives you a description of her menstrual cycles, no kind of like red flags for endometriosis or history of pelvic infections or things like that. And like many people, she's figured out, how her ovulation works. And, many people come in with, 3 different apps and, a flow chart that they printed off of Excel and a lot of other data around their minute by minute menstrual cycles. And, people who are data driven kind of get swallowed up by that section. But a lot of times people have done a lot of their, research on their menstrual cycles. And then, in this case, a sonohistogram with putting some air bubbles through the fallopian tubes is a good test to document patent tubes. Hysterosalpingogram is the traditional version of that, and if you have access to X-ray or ultrasound, those tests are generally a good assessment of fallopian tubes. And then his semen analysis was normal. So here we have this couple, and the question is, okay, well, what is our counseling for this couple? Young couple, mostly normal testing. So, is it, well, nothing is wrong, so keep trying, right? I think a lot of patients hear this when we tell them that the testing is normal. And again, if you think about most people's interactions with the healthcare system, this is not exactly how it goes, right? If you have a urinary tract infection, you go in, there's a test, there's a diagnosis, and then there's a treatment that goes along with it. So when tests come back normal, people say, okay, well, that means that everything's fine. And I think sometimes even as we counsel people, we sort of say, yeah, well, everything's normal, that's great. But in reality, it just means that we don't know what's going on with these people and why they're not getting pregnant. So again, the value of the test depends on its, what it's telling you. And most of these tests are helpful if they're abnormal, but not necessarily, when they're normal, it doesn't always tell you everything. You are young, so you have time, right? Okay, in this couple's case, right, they're in their late 20s. This is a little bit of a regional discussion, right? So, people in Manhattan who are 28 are like, children are like, well, I'm not going to think about getting pregnant for 12 years. I'm in Maine, and there are people who are, at 28, and they're like, everyone else I know already has 2 kids. So, it's a little bit of a mindset, but we can't always kind of convey our own, judgments and opinions on that. And, where were we all when we were 28 and, maybe in residency, and you're like, I don't want to have a kid then. But again, the younger people are, the less the less they're getting pregnant, the more concerning it is in reality, because these are people that should have gotten pregnant. So, a 38-year-old who's not pregnant over a year, you're like, okay, well, that might just be, the bad luck of trying to get pregnant. But, a young person in over 14 months really should have been pregnant. So that's more concerning to me. But again, kind of trying to reassure the patient sometimes goes the wrong way, and then they feel like you're not taking them seriously. Someone might say, yeah, well, nothing's wrong. Let's just try Clomid for a few months, and we'll sort of look at some of the data behind that. But just to sort of say, well, you're young, let's just do something easy that doesn't, cost a lot of money or add a lot of risk, but, may not be the best choice for them. You need IVF or assisted reproduction immediately, maybe a little bit of an overreaction. Again, I think there are some practitioners and people in the specialty profession might be like, hey, if you haven't gotten pregnant after this long, you're probably going to end up doing IVF. But again, for a patient that's not ready for that, you don't need to sort of put that on them right away and say, okay, well, this is the only way you're getting pregnant. And so that's, it has to be kind of a conversation with the patient. Based on the limited tests we have, we can't identify a cause, but given the fact that you haven't conceived, intervention is reasonable. And that's sort of my take on it, which is to say, like, we didn't really figure out why you're not getting pregnant, but the test that you are not passing is getting pregnant. And, based on population statistics we have, it's reasonable to talk about intervention. In general, again, I won't go into too much of the details, but like if you look at the chance that this couple is going to get pregnant in the next month on their own, it's around 1 to 3%. So it's not zero, but it's at a point where people may want to sort of choose intervention to try to increase the chances. When I talk to patients about this, I sort of like lay it out, and again, it depends on sort of the patient, but I kind of describe a formula of like, here's what we need to get you pregnant, right? And the math on this may not be that great, but the concept is here, which is to say, we need a good egg meeting a good sperm at the right time and in the right locations, right? So right location is sort of egg and sperm get together, and then also, make it back to the uterus. And those 4 things kind of in combination result in you getting pregnant. And there can be issues on any one of those fronts, right? The reason that we give people time to get pregnant, right, and say, okay, well, it's normal that people don't get pregnant every month they try, is that sometimes it's the wrong egg, sometimes it's the wrong sperm, sometimes people get the timing wrong. Sometimes there's location issues in terms of, you know, like the egg ovulated but just didn't get into the tube or something like that. So, you know, and people, like patients try to kind of explain this away a lot, where they say, oh, well, you know, you were traveling, or, you know, some couples where they're, you know, both kind of high functioning professionals will say, oh, well, you know, you were away for these months and then we missed this time, or, you know, you were sick. And, you know, all of that's fair, or you know, my job was really stressful and I was, you know, not sleeping well that month. You know, that kind of factors into the amount of time that we give people to get pregnant. But over a year, you know, in general, like, you should kind of be able to, you know, figure it out if it's something simple like that. But yeah, so each of these pieces is sort of part of the puzzle. And the question is, okay, well, what can we do to try to increase the odds? In terms of testing, right? So what are the tests that we have, right? Can we test that there's the good egg or the right egg? The answer is no. I mean, we can do tests of quantity, you know, and again, that whole like kind of ovarian reserve testing, we're looking at kind of how many eggs people have available, but, you know, overall that has very poor correlation with actual ability to get pregnant. And we've all seen patients that have low egg reserve who get pregnant very easily, and people with, you know, very normal egg reserves who don't. So, you know, and we can't see the egg, right? So you could have lovely ovulation, but if it's not the right egg, it doesn't matter if everything else is working. So, you know, getting an egg and getting a good egg aren't always the same thing. You know, good sperm, also kind of tricky, right? I mean, we can assess quantity of sperm. Our tests are mostly like pretty, you know, like 18th century in terms of like looking at sperm under a microscope, right? So my son's just doing a project about early microscopes, and I was like, wow, that was a long time ago that people looked at sperm under a microscope. And we're basically doing the same thing, right? We can count, we can say if it's moving, and we have, you know, slightly better microscopes now to look at morphology, but we don't really know if a good sperm is actually getting to the egg or not. So we can see sperm in a cup, but we don't know if it's getting where it needs to go. So, you know, there's some newer tests of DNA fragmentation and epigenetics testing for sperm that we're still trying to figure out what they mean, but there, you know, that may be some future directions on all of this. You know, right timing, again, this is the part that most people figure out and is usually not the problem. So people have tons of information about their menstrual cycles, and, you know, everybody is convinced that they have a luteal phase defect the longer they spend thinking about this, but most people are just finding the natural variation in their menstrual cycle. And, you know, in reality, you don't really want like 14 months worth of information about your menstrual cycle because you were hoping to be pregnant, you know, 8 months prior. And then the right location, again, like, our studies don't really tell us much about where things are happening, right? We can see fluid go through a fallopian tube and say that it's not blocked, but, you know, you can put a little coffee straw on somebody's uterus and watch fluid go through it, but it's not going to do all the things that it's supposed to do. And, you know, we have very little testing of like implantation or the right location. So, you know, the summary of all of this is that, like, all of the things that we care about that determine a pregnancy, we don't really have very helpful tests for. We can modulate some of these things. So we can't improve egg, you know, what can we modify? Can we make an egg better? Not really. There are some books that talk about, you know, kind of improving egg quality through different lifestyle measures. But for the most part, it's kind of like genetics and age. And yeah, there are some lifestyle things that accumulate over time, but it's unlikely that you're going to just totally reverse, you know, a 10-year smoking history by stopping smoking that day, or, you know, taking some supplements. So, you know, in general, like, we can't improve eggs, but we can get more of them. So I use kind of a raffle ticket analogy with patients, where I'm like, if you think of an egg like a raffle ticket and you're trying to win a raffle ticket, or win a raffle, getting more tickets increases your chances. And it's not likely that you're gonna, you know, get 2 winning tickets, but, you know, over time, if you haven't won a raffle, you know, getting multiple tickets gives you more chances. So that can be accomplished with more time, right? So each month there's another egg, or through ovarian stimulation, where we're getting people to produce extra eggs. We can't really modify sperm to make it better. Again, a little bit more on the sperm front in terms of lifestyle modifications and, you know, reducing smoking, you know, excess vices, alcohol, smoking, marijuana, you know, those are things that obviously lots of people do in lots of countries, and going back different generations in this country, people have smoked and done lots of things, and it hasn't totally prevented pregnancy. But for people who are struggling to get pregnant, minimizing those things may have an impact. But mostly when we're talking about unexplained infertility, we're talking about increasing the number of sperm that get there. And so that's either more trying over more months or doing something like IUI or intrauterine insemination. The timing thing, again, I'd say people sort of figure this out with apps and calendars and ovulation predictor kits. And we can use cycle monitoring to increase the timing, but most people, I would say, the time, unless they really have vastly irregular cycles or, PCOS patients, the timing piece is usually not the total problem. And then location is really the part that we're trying to modify, right? So doing IUI to put sperm into the system in a different way versus IVF, where we're taking things out, is kind of controlling more about where things are happening and where things end up in the long run. So this is just sort of like a graphic looking at the different options, and you can start with expectant management, which is just taking more time, right? So people would say, hey, I'm going to keep trying for a little bit longer as long as they know their odds of success. This is ovarian stimulation. We're getting more eggs, and there's Clomid and letrozole and different medications for that. IUI is kind of putting more sperm in the mix. Combining ovarian stimulation and IUI is a third option, and then IVF is kind of beyond that, where we're talking about more eggs and sperm in the right location. Oops. So let's go into some of the evidence behind any of that stuff, right? I mean, people have tried lots of those different things with different patients, and the question is, like, how many of them are actually valid options, and what are the increases in success? So I won't go into great detail of this other than to say that, with any committee opinion, it's not really, everybody kind of gets together and most people disagree on everything, and you end up with kind of like a mid-range review that everybody can agree on. But they obviously have lots of limitations in terms of, what studies are available and what they're looking at and where they came from, and comparisons across everything can be tricky. So let's start with the ovarian stimulation. That OS is sort of the new. It used to be called controlled ovarian hyperstimulation, and the new terminology is just call it ovarian stimulation, because people don't like the word hyperstimulation or control, so we're just calling it ovarian stimulation. So the idea is more eggs. So taking Clomid by itself, is that enough to do the trick? And overall, with Clomid alone, there aren't a ton of studies. There are a couple of lower quality studies, but overall, there are really not any kind of significant studies showing a benefit. There was a randomized trial showing, maybe a slightly higher rate of pregnancy, but not statistically significant compared to trying on your own versus Clomid versus letrozole. And this sort of makes sense, right? I mean, if you think about what Clomid or letrozole is doing, you might be ovulating like 1 extra egg in a month, right? So these are people who have ovulated 12 eggs over the last year, and now they're going to ovulate egg number 13 and 14 without changing anything else. It's unlikely that that's going to increase the chances of pregnancy, because they've already done it 12 times or more and it hasn't worked. So just getting them to ovulate an extra egg is not necessarily better. Now, sometimes people do this because the patient doesn't want to do anything else, or there's cost in all of that. But I think you have to really counsel people to be like, this isn't really considered much better than trying on your own, and it has some negative side effects. I mean, some of these medications have side effects, changes in cervical mucus and changes in endometrial lining. So it's not without risk, but it's sort of compelling because it's inexpensive and it sort of feels like a low risk thing with the patient. But I think, kind of giving them a clear vision of like, okay, well, here's where you're at, and you can try this, but it's not necessarily going to change the odds. Again, sometimes people do this just because they want to do something different, and even if it's the same as continuing to try on their own, they just need to feel like they're doing something different than just repeating the same process over and over again. This was a decent trial comparing expectant management to Clomid and IUI, and basically showing that expectant management and Clomid were almost identical in terms of live birth rate. IUI was better, and we'll talk about that next, but overall, not significant improvement over expectant management. So this article gave, or this opinion gave Clomid alone a sort of not recommended with, reasonable strength of evidence that it's not recommended. Letrozole is similar, again, in principle. I mean, it's different side effects, different mechanism of action, but overall the concept is the same, which is to say that like just ovulating an extra egg in a couple that's already tried for a year isn't necessarily effective. And I should say this is totally different than people where you're using this for what we call OI, or ovulation induction, right? So if somebody's got PCOS and they're not ovulating, then Clomid and letrozole alone are perfectly great and have been proven to be effective in that population. But these are people that already ovulate on their own, and it's important to distinguish those two factors, because sometimes people will be talking to their friend who's been through this, and they're like, oh, my friend took Clomid and she got pregnant, and that's maybe a different story if they ovulate or don't ovulate. I won't go into a great deal of this because most people aren't doing this anymore, but taking gonadotropins by themselves also is sort of increases risk of multiples, adds cost, and not necessarily much higher in terms of pregnancy rate overall. So that also gets kind of a not recommended approach. There are cases where people don't want to take medications, and I think most normal, healthy young people don't want to take medications. So, people will say, well, what if I just do insemination alone? And this has also been shown not to significantly increase the odds. And, in my opinion, like if you had to pick one thing alone, IUI makes more sense because you're at least changing the process by which the sperm gets to the eggs. But, in and of itself, the success rates are not significantly better than trying on your own. Where IUI starts to show benefit is when you add it with ovarian stimulation. So the idea is you're sort of getting more eggs and more sperm in the right place. So trying to sort of use the system, right? So location and timing, you're kind of leaving as is, but you're trying to get more work on the good egg or good sperm. So putting more into the system. Yeah, there have been some decent studies showing that compared to expectant management alone, there's an increase in pregnancy and live birth rate using Clomid and IUI. And letrozole and IUI are sort of, I would say somewhat interchangeable at this point. I'll leave these in this talk, but I won't go into too much of the detail just because I think the principles are the important part and not the data. But yeah, overall Clomid IUI gets a sort of recommended strength of evidence A, meaning we have decent studies showing that that it's more effective than control of just trying on your own. Letrozole and IUI also has a similar profile, and again, you would sort of expect this just based on the fact that they're kind of similar in terms of outcome of ovulation, and some people do better with one than the other compared to side effects. I still use Clomid as kind of a default starting point just because it's been around longer, but if somebody had side effects or didn't tolerate it, I'm very comfortable switching to letrozole. This was sort of the best study from the New England Journal of Medicine a few years ago now, but just kind of looking at people with unexplained infertility and comparing, Clomid, letrozole, and gonadotropin IUI. And on the upper panel there, you can sort of see the cumulative pregnancy rate plot, and gonadotropin's was superior to Clomid and letrozole, but on the lower part, you see the multiple rate, and gonadotropin's had a significantly higher rate of twins, and then multiple cases of triplets, which for most of us is sort of not worth the added benefit of pregnancy. So and Clomid and letrozole were not statistically different in this group slightly better on the multiples and rates, but overall, the suggestion is that Clomid and letrozole are both adequate with IUI to increase live birth rate. And there are times where people still use gonadotropin and IUI, but you have to be sort of presented with that caution around the higher order multiple risk. So letrozole and IUI gets a strength of evidence A and recommended as an alternative to Clomid. Again, mostly just the FDA rating for letrozole is not, it doesn't have an approval for this. And so people get a little bit more antsy about doing that. But again, I think overall, clinically, enough people have used this to say that they're somewhat interchangeable. And then the gonadotropin piece mostly refers back to that Diamond article, and then this one other one showing sort of a higher overall pregnancy rate, but also a higher multiple rate, and generally that has downgraded the recommendation just based on the risk of multiples. So even though there's good evidence that it increases pregnancy rate, clinically we use it less because of the risks. This was another big randomized trial that was done at Boston IVF, and comparing people going through IUI before moving to IVF and how many cycles they went, and basically showing that Clomid and IUI were as efficient as doing Clomid IUI for 3 cycles and then FSH IUI for 3 cycles. So again, arguing that doing more cycles of IUI with FSH is not necessarily additive to just trying the Clomid alone, and if neither of those works, moving on to IVF in a somewhat timely fashion. So statistically around 3 cycles is kind of where that argument happens. IVF is the not necessarily the end point, but kind of the next step in terms of using everybody's own eggs and sperm. And the idea here is, again, we're just taking more control of the process. It still requires the right egg and the right sperm and all of that stuff. If people don't have good eggs, then taking them out of them isn't going to make it better. If people's sperm and eggs don't work together, putting them together outside the body isn't going to fix that. But for most people, it's not an absolute issue, and they have some good eggs and some good sperm, and we just need to get them together in a more efficient way. And so rather than taking 1 year to go through 12 eggs, we can go through 12 eggs in 1 day. And that's, kind of speaks to the efficiency of the process. And people always think, oh, well, you're making my eggs better, but we're not making the eggs any better. We're just getting more of them. And so it sort of goes back to that raffle concept of, okay, well, now we're just working in a higher multiple of eggs. There are a number of studies looking at the outcomes of IVF, and overall compared to IUI and compared to other modalities, the live birth rates or pregnancy rates are higher, live birth rates are higher, and the biggest trade-off with IVF is just cost and intervention. So again, many young healthy people aren't looking to start injecting themselves with hormones or having lots of blood tests and ultrasounds and needles put into their ovaries. So even if it's a more effective approach, the intervention has to be weighed against the benefit. And again, a lot depends on where you live and what your access to care is. So from an insurance standpoint and just availability of local clinics and resources, this is also not something that sort of has universal acceptance across the country, where some people don't have easy access to these kind of treatments, and it's hard to sort of say, well, this is the gold standard of treatment if lots of people can't afford it or get to it. Those things are starting to change. Slowly more employers are started adding these benefits independent of state mandates, and different, more and more states are starting to kind of recognize that they have to make some of these decisions. Our state in Maine, and I live in New Hampshire, both recently added fertility benefits, even in like a relatively conservative legislation and governors. And part of the reason is that we're states that are pretty lopsided in our populations, and so there's not as many young people and there's not as many children, and there's lots of older people in our states. And so just in terms of like keeping young people in the state and having them reproduce, and that's the argument that's much easier to get through a legislation than, people feel bad that they can't get pregnant, which people have tried, and that doesn't move the legislation. So it's a little bit cynical, but the reality is if you have more voters and more people in schools and more kids around, then some of the legislation gets through better that way. So we just passed a bill in Maine last month that's supposed to be going into effect in 2024. So we'll see how that goes. I won't go into age too much here, but there is this sort of trial again from an age perspective, as mostly as women's eggs get older, the number of eggs is lower and the quality of those eggs is lower, and so it is expected that it's harder for people to get pregnant during those times, and so using things like IVF becomes more effective because you need to sort of go through multiple eggs to try to find the right egg. So 38 and beyond, the success rates of IUI are generally pretty low, and we're hesitant to recommend that as a first line because people, it's coming at the expense of time, and going through additional procedures that aren't working it may not be worthwhile. That said, a 40-year-old who can only produce 2 eggs in an IVF cycle doesn't really have a different chance of success as a 40-year-old who's taking Clomid and producing 2 eggs. So, most of the benefit of IVF for the age-related fertility issues is getting more eggs. So if you can't do that, then IVF isn't really that much more successful unless there's something else going on, right? So if somebody has blocked tubes or a sperm count, but then they're sort of out of the range of what we call unexplained infertility. But the reason that IVF success rates drop off with age is mostly because there's less likelihood of finding that good egg. And so in that equation, if you can't find the right egg, then it doesn't matter if you do all the other steps. So IVF, sort of, this is a very, I would say, politically couched statement that you can tell comes from a big committee of people, which is to say it's recommended to attempt, if you've tried other things and all of that, but in reality, it's sort of on the pathway for some people and not for others. And the question is, okay, well, when do we, move that into the equation? And the last point is just to sort of say that all of these treatments need to be kind of done in discussion with the patient about what the actual success rates are and what you're trying to accomplish and what the outcomes are. And I think I sort of try to really demystify this for the patient and be like, Clomid isn't a magic pill that helps you get pregnant. It's a pill that tricks your brain into thinking you're not ovulating, and so you send enough stimulation to release an extra egg. But producing 2 eggs may not be enough to move the needle enough, because it's like trying for 2 months, and you could also just try for 2 months, and that doesn't necessarily increase your odds if you've tried for a long time on your own. So in the same way that I wouldn't say, jump straight to IVF because the chances aren't going to be great. For some people, doing something is really what they want to do, and for some people, doing something is not what they want to do. And I think you have to just sort of share the information with people enough that they understand what they're doing. From a general GYN perspective, and I was a general GYN before I went into my fellowship, the challenge is time. And I have an hour to go over this with my new patients and sort of go into all this detail with them. And when you're sort of dealing with a host of other things in your general practice, you don't have time to necessarily explain all of these things. And so I would say in general, referring people to a specialist, even if you don't think the patient needs to do anything, just to sort of give them a moment to kind of process the information. And sometimes we'll be like, hey, you are in a good place, you can take a little longer and see what happens. We don't always sort of push people into treatment. And again, that varies, by practice and location, but I always am happy to meet somebody that's sort of panicking at 8 months and say, yep, here's where this is going to go if you don't get pregnant over the next few months, and here's what we can do and here's what we can't do. Rather than somebody coming in after 18 months and they're exhausted and they've done Clomid and a bunch of stuff with their generalists, and they're like, well, now I just can't even, like think straight about this. So, it's fine to, get people to someone else just to sort of spend more time going over the principles. This is sort of a summary of the main points here in this committee opinion, and overall, like, ovarian stimulation by itself doesn't seem to be that effective for this population, nor is IUI by itself. And again, it's not that you would never do these things, but you have to sort of do it in some conjunction with the patient to talk about their trade-offs. Ovarian stimulation with IUI seems to be a marginal increase in pregnancy for many couples in this situation, but within limits. So, usually 3 or 4 attempts at Clomid and IUI is enough to prove that people have gotten pregnant or not. And if they don't, then it's, kind of time to think about moving on. And then, IVF may not be the first line, but it's an option for people with access that, haven't succeeded with other things. So just to sort of briefly revisit our couple, this is a couple where I would say, do 3 cycles of Clomid and IUI or letrozole and IUI, see if you get pregnant. If you do, great. If you don't, then IVF is sort of your next step. And it doesn't mean that you need to do IVF on month number 4, but, for younger people, they may take a little bit of time to regroup financially and then plan for IVF down the road, and not sort of keep flogging them with Clomid or IUI or things that if it's not working. And this is sort of this like, well, should we just be talking about people going immediately to IVF? And I think this is a real sort of shared decision moment with a lot of people. And, right now it's not accessible, it's not affordable. And, yes, multiple pregnancy rates are lower than they were, but not completely. And so we haven't like eliminated that from the risk. So I think for couples that are mapping out their future and they're like, we want to have 3 children and we're 32 years old, and like just doing the math on how long that takes, sometimes doing IVF may help those people make embryos now that they can use for the future. But again, that's a sort of really individual decision, not a medical one. So I'll stop there, and I'm happy to take questions and talk offline if there's other questions that come up afterwards.
Thank you, Dr. Lannon. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions panel in your attendee control panel. Dr. Lannon, our first question is, if a patient has been trying to conceive unsuccessfully, what testing would you like to see prior to a referral?
Yeah, so I will sort of, for my practice, I will take people in any state of testing. And again, this is very sort of regional and practice specific. Some practices are very fussy and they kind of want to redo all of their tests that you've done. I happen to, be in a state where this isn't covered. And so, people might be paying for some of these tests. So I will take whatever tests have been done. I think, if you think about just sort of the fertility tests that are possible, like a semen analysis and some sort of assessment of uterine cavity and fallopian tubes is sort of the minimum amount of information to figure out like what's going on with a couple. Whether you get like, carrier screening and ovarian reserve testing and all of that. I mean, we're going to sort of eventually do some of that stuff anyway, just to help us kind of like, create more sort of treatment stratification. So, but, if you needed to just sort of say like, what are the things that we can really, if you think back through this whole talk, right, it's basically, do you have open tubes? Are you ovulating, and do you have sperm? And so, usually when I meet a young couple and they're not getting pregnant, they're more likely to have tubal issues or sperm issues than anybody else, just because they're not getting pregnant. And even if their testing comes out normal, I'm like, there's probably still an issue with your fallopian tube or something that we're not seeing. But those are kind of the basic tests that most people have access to at the general gynecology level. And as I said, like I'm always happy if people just come straight in and haven't done any testing. We'll figure it out when we get here, but that can help kind of prepare people a little bit more.
Thank you. Our next question is, do you have a recommendation of how long a patient should try on their own before coming in?
So, the medical answer to this is, 6 months for people 35 and older and 1 year for people under 35. I generally tell people, like, when you are starting to panic about this, that's a time to have the conversation. And for some people, that's like month 2, right? And we all know those patients who are like freaking out and they're like, I'm not getting pregnant and I've been trying for 2 months. And it doesn't mean that like you need to sort of initiate a whole workup and create a panic around it. But I think, and this is again where you can decide, if you want to refer somebody out. But I'm always happy to have a conversation with people about what the reality is. And, here's the likelihood of pregnancy per month, and here's what we can do, and here's, how long you should try certain things. But, a lot of people get really anxious and stressed and depressed and any number of things as they're trying this process. And, I think the sooner we can intervene on that, the easier it makes the process for people. And so you sort of have to overlap this like medical component with the psychological component. And, some people have unrealistic expectations about how it's going to work, but, in reality, like nobody has any education about, human reproduction in our education system, or very basic. So, I mean, the number of men you talk to who are like, don't understand why their 44-year-old wife isn't getting pregnant easily. It's like astounding to me that people don't know that there's a difference. But yeah, so I think a lot of people kind of, I see people kind of down the line and they're like, well, I went in at like 6 months and I was really worried, and my doctor said, well, we're not going to do anything until you get to 12 months, right? Which is like medically appropriate, but I think you can say it in a different way, which is to say like, yeah, like this is concerning, and like here's what we're going to do, and sort of create a game plan. Because I think sometimes people feel like, if you, it's sort of that, you're young, don't worry about it vibe. Like I have, 23-year-olds who, have tried for 8 months, and I'm like, well, that's really abnormal that you're not pregnant. But, I think if you sort of like create a gate where you're like, you can't do anything until 12 months, then, people get resentful if they don't get pregnant at 12 months. And I tell people, look, your gynecologist isn't doing that to be mean, but like everybody they talk to at 8 months feels that way. And like a bunch of them are going to get pregnant by month number 9, 10, and 11, and they never have to come see me. But, if you sense that a patient's really freaking out about it, or really, kind of getting stressed, like that's a time where you can say, you know what, like, we're not going to necessarily panic about this, but if you want to see a specialist and sort of like start thinking through the plan, like you can send somebody to me. I'm not going to be like, oh, you need to do IUI tomorrow, but I might say like, here's, at least have the time to kind of walk them through, here's what we know, here's what we don't know, and kind of come up with that a game plan so that they at least feel like they're a little bit more in control of the situation.
Thank you. The next question is the case of a 36-year-old female who always ovulates late, like their LH surge tested usually at 28 days. What are your thoughts on her egg quality, age, etc.?
Yeah, so those are people that are always, a little tricky if they're really ovulating like that late in the cycle, right? I mean, I guess one question is sort of, okay, what's the total cycle length? So if somebody ovulates, day 28 of their cycle, and then they get a period, 10 to 14 days later, then really they're probably just like having a, kind of abnormally long follicular phase, and they're probably in like, sort of a polycystic ovary variant, or maybe a hypothalamic dysfunction variant. So sometimes you have to do some monitoring with those people to kind of figure out what's actually going on. So there are people that might just sort of do nothing in their cycle, and then, around day 14, they go through a normal menstrual cycle, but it's just 14 days of nothing while they're getting ready. And those are people that might benefit from something like Clomid or Letrozole to kind of just boost the system a little bit, and not necessarily to improve their ovulation, but just to kind of compress the cycle so it's a little bit more predictable. It doesn't translate to egg quality. I mean, I think we can't necessarily always interpret egg quality from cycle length. I think, if somebody's older and they're having shorter cycles and they're having, declines in their egg reserve, then we start to say, okay, well, that's probably, there's some decline in egg quality. But longer cycles don't always translate into something worse. So with that person, I might, yeah, just try to do some, and if you have access to doing kind of timed blood and ultrasounds at like day 14 and 18 to figure out what's going on. Sometimes people use ovulation predictor kits and they're just not getting it right, and it just doesn't work for them, particularly PCO people where their LH levels are a little high. You can get a lot of false positives or negatives. So if it's sort of inconsistent or not, doesn't seem like it's making sense, maybe doing some kind of timed estrogen, progesterone and ultrasounds along a cycle to kind of figure out what's actually going on.
The next question is, are blood karyotypes offered to rule out an inherited chromosome rearrangement as possible etiology to their infertility?
These are tricky. I mean, there are definitely people that have translocations and other chromosomal rearrangements. We generally sort of think of testing those in people that have recurrent pregnancy loss. So if they have a sort of minor translocation, they're very likely to get pregnant and then have a miscarriage. It isn't part of the like standard evaluation for infertility, but there are times that we check on it even in people that haven't had miscarriages, and more frequently, like people who've never been pregnant, they do IVF and none of their embryos grow well, or they don't get pregnant even with embryos that look normal, and we might check a karyotype. Or if somebody has a sort of suspicion based on their family where there's lots of other miscarriages in prior generations, and you're like, we should sort of investigate this. But I would say it's probably not a first line test, but it's always something to keep in the back of your mind that like there are a surprising number of people that have translocations, and it's important to keep it on the radar.
And this is our last question. Recently, a lot of women have high AMH. Can you explain the significance or concerns with having a high AMH?
Yeah, so high AMH is sort of a tricky one. So high AMH has been correlated primarily with PCOS, and it sort of makes sense. Like AMH is produced by the sort of cells, the support cells in active eggs. So, if you measure an AMH on like a pre-pubertal 6-year-old, right, they have like lots of eggs in their ovary, but their AMH is going to be low because there's no active eggs there. So it isn't a reflection of like how many eggs you have available for the rest of your life. It's just sort of like what's available in that month. Likewise, people that have been on chronic suppression with birth control pills or Lupron for endometriosis or something like that, we'll see their AMHs temporarily go down because it's not measuring active eggs. But PCOS patients have a lot of active follicles, and so it's normal to see a higher AMH. So if you diagnose with somebody with PCOS and you get an AMH and it's high, that sort of like correlates. The question is high AMH diagnostic of PCOS? And the answer is no. And it's not in the definitions of PCOS, partly because most of those definitions were made before we were checking AMHs on people. But it's I would say a suggestion, but not necessarily a diagnosis. And then there are these people that we kind of call like, PCO-ish or like PCO spectrum. So it's like not a formal diagnosis, but there are people that sort of have some of the characteristics, but not all. And the definition of PCOS is going to change in our lifetime. Like it's just, it's become too big a diagnosis now, and like there's probably going to be a switch to calling it like functional ovarian hyperandrogenism or something, where we sort of describe the people that have, hyperandrogenism or hyperandrogenemia as people with PCOS, and then we're going to come up with other terms for other subcategories, like the lean people with PCOS and people that have lots of follicles and high AMHs, but they don't have irregular cycles. And so, yeah, so we don't really know what to do with people with high AMH, other than to say that like, it is not a non-issue from a fertility standpoint. So like traditionally, we're like, oh, if you have high AMH, it means you have a good egg supply. But those people don't, if they end up in IVF, they don't necessarily stimulate normally, and they have, they kind of over respond but don't produce enough mature eggs and things like that. So it's a tricky group, and I think, as we get more kind of background information about the general population of AMH, and it's really been over the last, sort of 5 to 10 years that we've kind of had more and more data on AMH. So what we really need is kind of a like longitudinal assessment of AMH across a longer time period, especially in terms of predicting. People always ask, well, if like the other version of this is a young person with a low AMH, what does that mean? Right? We don't necessarily know. Does that mean they're going to go into menopause sooner? Does that mean they're going to run out of eggs sooner? Does that affect their fertility? So I think we're still trying to answer those questions, but in general, I would say, like, particularly as a general OBGYN, like, don't check AMH casually, just because unless you like have a plan to go over it with the patient, like it's most of the time it's fine, but it's kind of like checking a white count on a patient in a hospital that you don't really want to know the answer to. Like once it comes back abnormal, you got to explain it. So, it's a risky test if you're like, oh shoot, well, we were expecting it to be normal. But more and more people are getting these things kind of through like, mail order kits like Modern Fertility, and then they're sort of coming in with this thing and like, okay, well, what does this mean? And yeah, I would sort of say if you have someone with a high AMH but everything else is normal, I would kind of say, well, it's probably fine and ignore it. But if they have other issues like ovulatory dysfunction and something like that, then you're sort of obliged to work that piece up as opposed to just sort of diagnosing them with high AMH. So.
Thank you, Dr. Lannon. And thank
Yeah.
you. Yeah.
Go ahead. Yeah. I was going to say thanks everybody for joining, and we'll see you.
Thank you. We appreciate it. And we thank you everyone for attending today's webinar as well, Evidence-Based Approach to Unexplained Infertility. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. On behalf of Boston IVF and Dr. Lannon, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Lannon.
Take care.